would like to thank Sarah for organizing this, with Jill who put everything up, and Audrey who actually reached me. And before I start every talk, I always have to do a disclosure of multiple conflicts of interest. And I'm just mentioning that these conflicts of interest is because I work in a clinic in Quebec City where we actually have an asthma teaching center with an inhalation therapist, and she's supported by the pharmaceutical companies. And so she's a retired inhalation therapist, and she comes to do asthma teaching in PFT starting the ages of 4.
You work in a clinic in Quebec?
Yeah, my family's in Quebec, and so I work there too. And so there are a lot of highlights in respirology this fall. I think one of the highlights was last week. So it was the annual meeting of the FMOQ, and there were 2 days that were on respirology. And all the talks were recorded, and you have them on your website. And Thursday morning was only about asthma. And so Dr. Mathieu Simon from l'UCPQ gave a beautiful talk. It was the first talk about PFTs. And he gives you all the guidelines on how to interpret the different spirometries with the Colin Challenge. And the second talk is very interesting. It's Dr. Christelle Godbout, and her specialty is all the different inhalers. What are all the new ones, what are their uses? And actually, Dr. Godbout is launching a website on November 17th. It's going to be called Pharmapedia. And sorry, Pedia is not for pediatrics, it's for Wikipedia, and they're playing with the words. But it's going to be a huge website for pediatrics and adults with all the inhalers, the recommended dosages by Health Canada, what we use as dosages in clinics, what are the maximum dosages, and all the recommendations are going to be there. And of course, this is the purpose of the talk. INESSS on September 25th, so it's only been a few weeks, published a huge report that is really the official guideline on how to approach and how to treat asthma in children and adults. And the report is in 3 parts, and so you have the complete review of the literature that has 107 pages with a lot of information. And you have the annex at about 20 pages, and you have the clinical tool that's about 12 pages, and this is what we're going to review this evening. But I really think that that clinical tool is going to become the reference. INESSS is asking us not to say, this is what we saw in GINA, the ERS, the CTS, the CPS. They really want us to refer now to what the INESSS is recommending. And from pediatrics, we have Dr. Francine Duchamp, who is always going to be our leader. And we have also Dr. Zofia Zisman-Coleman from the Montreal Children's Hospital, who worked on this project. And so I'm sorry the slides aren't finished, but I just want to mention that I give a lot of asthma talks, but I completely redid this talk, and I asked INESSS permission to show to you what they really recommended. And so the way we're going to get by it is asthma is always presented in different age groups, and we're going to start with the young children below the age of 5, and I'm going to start with clinical cases to highlight what are the key messages from INESSS. And so this is Rose. Actually, she was here, and so she's a term-born child who, like many other children, entered daycare in September 2022, age 1, had an ear infection 2 weeks later, and you see in the office September 30th when there are a lot of viruses, and she's having her first lower airway exacerbation. And so you hear her wheezing, she has a ton bit of indrawing, you hear the wheezing, and you decide, you're debating, is this a bronchiolitis or is this an asthma exacerbation? You give her 2 puffs of Ventolin, the clinical symptoms go away, and the clinical signs subside completely. And so you decide to discharge her with only Ventolin after teaching her how to use an aereo chamber. So is this what we're supposed to be doing? We're going to check what INESSS is telling us about this. And so we all know that the main symptoms in children are cough, difficulty breathing, and wheezing. We also know that they're more symptomatic during the night when they wake up in the morning and on exertion. And the main trigger below the age of 5 are viruses. And so these are the key messages. Now we have to spend a moment on what is the diagnosis of asthma, because a lot of information is in the diagnosis. And so the INESSS takes, they just recopied what the CTS came as a consensus for the diagnosis of asthma in preschool children in 2021. And so you have 2 steps, and you always have 2 ways of making the diagnosis of asthma. So the first way is when you meet Rose, and this is the one that we're all comfortable with. So you have a parent coming in complaining about symptoms. We hear the wheezing. When we listen on auscultation, we hear wheezing again. We give Ventolin. We notice the reversibility, and we're all comfortable talking about asthma. but this is not the most frequent presentation in preschool children. And so in preschool children, we most frequently have what we call the alternative diagnosis. And the alternative diagnosis is when you have any caregiver or parent who comes to you with a convincing report of symptoms. And so when you see the child is well. When you examine the child, the auscultation is clear. But the caregiver is saying, my kid is coughing, is having too many colds, prolonged colds, there's too much coughing, difficulty breathing, occasional wheezing, but you don't notice anything. And so what do they recommend? They recommend that we start an asthma treatment with a moderate dose of inhaled steroids for 3 months and reassess the child. The problem when we reassess the child is, once again, the only thing we have is the report of the parent or the caregiver that says yes or no, did the treatment work? And so the main challenge below the age of 5 is we have a difficult access to PFTs. And so the most frequent diagnosis of asthma in young children is on the report of the parents or the caregiver without having any clinical signs. And why are they talking to us about this issue is because when we do PFTs, we always meet a child with very low PFTs, and the parents say, well, we always found that our child had difficulty breathing, shortness of breath, too much coughing, but whenever we brought her in to see the doctor, they never heard anything, so they weren't comfortable starting inhalers. And so in preschool children, on a convincing report, the official recommendation is 3 months, moderate dose inhaled steroids, a written plan, as needed SABA, and you reassess the child 3 months later to see what is the evolution under asthma treatment. And so in the principles of treatment, there's a huge difference in between children and adults, and this difference goes all the way to the age of 11. So it's only in children 11 and below that we're still allowed to prescribe Ventolin as a single therapy. And so this is not accepted anymore at all beyond the age of 12. However, it's noted all over the report, and they say you're still allowed to, so with Rose, when we gave only Ventolin, we're still allowed to do it below the age of 11. However, what's most important is that this is only step 1 of treatment. And so we're going to go a bit further to know what are the different steps. And before we go through the different steps of treatment in preschool children, we have to understand the definition of an exacerbation according to INESSS. And so for them, a severe exacerbation is any asthma exacerbation where we decided to give systemic steroids. So if you ever see a kid and you say, well, he has enough difficulty breathing for me to prescribe Dexa, Pediapred, prednisone, we consider it's a severe exacerbation. So you have it on top. I'm sorry, I'm not following here, but non-severe is when you're not giving systemic steroids. Severe is you decided to give systemic steroids. And so let's see what happens with Rose. And so after you see her, she ends up going to the emergency room. And once she goes to the emergency room, they give her 1 dose of Dexa and everything goes away. You see in follow-up, she had another ear infection. She went back to the ER for a laryngitis, and then the parents took her away from the daycare until the end of January because she was sick too much. And she returned to daycare at beginning February, and then in March, she has another exacerbation. She goes back to the ER, and then she gets another dose of Dexa. It's the 3rd dosage because she had a laryngitis, and they start Alvesco 200 daily for 3 months. And so these are the 3 steps that we follow in preschool children. And so the criteria that tells us what step we're treating is has there been a severe exacerbation in the previous 12 months. So if a preschool child has had Dexa once in the prior 12 months, we're automatically step 3. And so Linus, only for asthma. Yeah, only for asthma. So if in the past 12 months, a child has had Dexa once, it doesn't matter where it was, in clinic or in the ER, we're automatically step 3. We're going to see a bit later what is step 3. They know that very frequently in pediatrics we're step 1. So step 1 is when the children use the inhalers as needed, either because we recommended it or because the parents do it. And so for step 1, there are 3 criteria. As needed, Linus says it's not approved by Health Canada, but we know that inhaled steroids should not be used only as an as-needed basis. But they say that if a child is using as-needed inhalers, the 3 criteria is in the previous 12 months, the maximum are 3 episodes. in between episodes, the child is completely asymptomatic, and in the previous 12 months, the child has never received systemic steroids. And so those are the criteria for step 1, using inhalers as needed. So if you find that the child is more sick and you're going to step 2 is when you're using a low dose of inhaled steroids. You can also use only single layer as a single therapy. But when you're step 2, in the previous 12 months, the child has never received systemic steroids for asthma. The minute there has been systemic steroids, we're automatically step 3. And so we're going to go a bit further. And so just to resume the outline that Health Canada doesn't approve the as needed, they say that we are allowed to use as needed Ventolin or as needed, well, we use as needed also inhaled steroids, but the limit are 3 episodes in the past 12 months. In between, the child is asymptomatic and in no situation systemic steroids. And if there's been 1 exacerbation requiring systemic steroids, we're automatically step 3. And so these are the different steps. And so for children before the age of 5, they made it the most simple possible. And we're trying to review what are the options we have. So when we're talking about low-dose inhaled steroids, we only have 3 choices. You have beclomethasone, which is Cuvard, ciclizumide, which is Alvesco, and you have fluticasone, which is Flovent. The low dose is 100, and so for Cuvard, it's 50 twice a day. For Alvesco, it's 100 once a day. And for Flovent, the low dose goes all the way up to 200. And so you use the inhaler of 50, and you can give all the way up to 2 puffs twice a day, which gives 200, and you don't go beyond. When you come to the moderate dose for Cuvard and Alvesco, it's 200, but for Flovent, they allow us to go up to 250 to use the inhaler of 125, but never beyond. And actually, this is one of the key messages of INESSS. For Flovent, they say up to the age of 16, we should never be beyond 400 micrograms because of the systemic side effects. And so the maximum dosages of Flovent during growth all the way up to the age of 16 is 400. And so these are the mild and moderate doses, and we also have as an option single layer, and that's it. And so when we look at the chart, the young children are completely on the left side. The mild dose is you have Cuvard 100, that's 50 twice a day. You have Alvesco 100, or you have Flovent 50, 1 or 2 puffs morning and night for a total of 200. When you increase to moderate, you have Alvesco 200, Cuvard 100 twice a day, or Flovent 125 twice a day, that gives 250. What's most important are the small characters. They recognize that they're recommending this and it's not approved by Health Canada. Actually, it's easier to tell you what does Health Canada approve in young children. And so we're allowed to use Flovent starting the age of 1, 200 up to 4, 4 to 16, the maximum is 400. We're allowed to use beclomethasone starting the age of 5, and we're allowed to use mometazone starting the age of 4, but we don't have it. The only mometazone available is Asthma, that's a dry powder that we can use starting the age of 6, so there's nothing available for 5 and below. And so basically Health Canada doesn't approve most of what INESSS is saying, but nevertheless, for children below the age of 5, these are the recommendations for now.
So do you want questions in between, or you want?
Yeah, go ahead.
Have so many already, but just that one simple one. The fluticasone recommendation is with the dosing of 200, 400 is based on the U.S. formulation. We don't even have that here.
I know.
So then,
I know.
For
So
INESSS to come out with this is what we want you to follow, and then to
Yeah.
have nonsense in there is confusing enough.
because the only thing I figured out for is to use 125, 2 in the morning and 1 in the evening, so you get 375. That's all I figured out.
Okay. I wish they would have written that. And just because people are already going to be challenged by.
Yeah, because we can't, the more puffs a kid has to take, the less adherence we have. And so I don't see any other solution but saying 125, or they want us to switch to the discus. But the discus is 100 or it's 250, and so no, we're not any further.
The other question I really have is going right back to Rose day
Yeah.
1.
Yeah.
Of just, I understand it's the new guideline of just using a beta-2 agonist.
This is forbidden. We're going to see at the end of the talk, it's forbidden starting the age of 12. And so when I say this, the adults say, she's kidding, she's going to change the message, but I have to say it because they wrote it down. And they really write that we're allowed to use SABA alone below the age of 11, but they mention it's step 1. Step 1 are as needed inhalers, maximum 3 episodes, 12 months, no symptoms, no systemic
So
steroids.
this implies that a bronchospasm, which I know is not a term we like to use anymore either, a reactive airway can be purely bronchospastic reactive without any inflammation, because it,
No, I
well,
don't believe in
I don't
this.
believe it either, and that's why I'm having a lot of trouble that this is a new guideline, state of the art, and it doesn't include ICS. It doesn't make sense on the basis of
Yeah.
pathophysiology.
Because you understand what he's saying is starting the age of 12, like in adults, you're never allowed to prescribe Ventolin. They're never allowed to take Ventolin without taking an ICS automatically. And they're using a lot the combination ICS formoterol. And this is it. They don't have any literature. They don't have the documentation. So they cut it off at 11. And so we see a 10-year-old, we're not supposed to do it, and we see a 12-year-old, and we have to be on smart MART and only on combination therapy, and always given inhaled steroid with the formoterol. But I really I'm sticking to the message. I'm not saying what I'm doing. I'm not saying what I think, but I'm really reading what INESSS said, and I'm showing you. I asked them, I said, can I show what you wrote? And they said yes, and I'm showing you where they wrote it, and I'm just repeating what they said.
I just want to do a parallel because in INESSS having a lot of like guidelines for like other infections, we don't necessarily follow it. Okay, so I think it's a guideline, so we just have to see it as face value for like a review of the literature, and then after we just adapt to what we're doing. But if we base to the CTS and they base themselves on it, it's SABA or ICS low dose for step 1. So we can choose ICS low dose.
Yeah, but in children below the age of 5, when we use a low dose of inhaled steroid, it's step 2. And so when at step 1 is only Ventolin, we know that in pediatrics we give Ventolin and Alvesco Fluent as needed. Episodic use, we know we do it, but they can't say it because Health Canada says no. So step 1 is only inhalers as needed. And this is why they say, yes, you can do it, but they really make rules of when you can do it. And finally, it's not a very large group of patients. What kid has only 3 exacerbations in 1 year, 2 weeks, no symptoms, no systemic steroids? It's not a frequent presentation, and you're going to see it's going to be the same thing for 6 and above. They say, yes, you can do it, but they narrow it down to very specific criteria that not many patients are going to meet those criteria.
So Dr. Duchamp was also invited for one of our CMEs, and she said exactly the contrary, that we have to jump on the ICS very quickly because we have the pulmonary remodeling, and it's very important to preserve pulmonary function on the long run. So our habit was really to just jump to all this 100.
Yeah, but now they say that when we start, they really want us to start at a moderate dose of 200, and after they're stable for 3 months, then we come down to a lower dose. Or if they're not doing well, then we step up. And so when we initiate treatment, if they've had 1 exacerbation requiring DEXA, we have to start at a moderate dose. And if you start at a low dose, it's because you're combining it with the single layer automatically. Single layer automatically. So if you want to work with a low dose, it's because you're starting low dose and single layer. So those are the 2 options we have. The alternative is low dose with single layer, but the preferred is to give a moderate dose. And so this is what they're really saying. 1 exacerbation, systemic steroids, moderate dose that you start off with immediately. And so, yes?
I'm sorry, I'm rushing from work. Is it too complicated to get a little rundown of what I missed? Yeah, there's a lot?
We'll just continue because
Okay.
INESSS asthma guidelines.
Yeah, we're going through the new guidelines for INESSS, and actually we just went through the summary of the key messages. And so really we're just going through the children 5 and younger. And so if they've had 1 severe exacerbation in 12 months requiring systemic steroids, they recommend to start them off for 3 months on a moderate dose of inhaled steroids. And if they've not had a severe, when we use the inhalers as needed, the limits are 3 episodes, 1 year, no symptoms in between, and in the past year, the child has not received systemic steroids.
And when you say intermittent treatment is also low, moderate dose of ICS, it's not just SABA?
Exactly, it's both. But they can't say it because Health Canada says not to use the ICS as needed.
So what is the Ventolin?
Yeah. Yeah, because they say that below.
As needed, it means Ventolin only.
Yeah. And that is step 1. Step 1 is only 3 episodes in 1 year, yeah.
So when you say intermittent, it's intermittent versus continuous, because we do
Exactly.
a lot of continuous treatments.
And when we do continuous, if we're on a low dose, or if we're only on single layer, in the previous 12 months, the kid has not had any systemic steroids. The minute we have to give DEXA, we have to go up to moderate dose, or continuous, or low dose with single layer. Those are the two options.
Just a question about the initial presentation. It's Rose's first
Yeah.
episode, and she has reversible bronchospasm.
Yeah.
In our minds, that's asthma right away.
Suspected asthma.
Suspected asthma.
She's
I
two, remember,
thought-
she's 2 years old.
Right, so I thought it was 2 episodes of bronchospasm with reversibility.
And,
with,
yeah.
with ventilator
But now-
reversibility, that was okay enough to say she has asthma.
But now they're saying that one exacerbation you treat. So you give DEXA once, you have to treat.
Okay, but look, not saying DEXA. She just presents in your office. She's
Yeah.
easy. You give her Ventolin. She reverses. First episode ever.
That was
She
fine.
has a diagnosis of asthma, right?
No, suspected.
Suspected. Second episode that she has 3 weeks later, a month later, she's asthmatic now.
Exactly, but what happened after the first episode is she went to the ER. And so when we gave the DEXA, we were supposed to
Then you're
start,
automatically boosting her.
then we have to start the moderate dose. And so,
Sorry, can I just ask, based on this, I'm just a little confused. Based on the guidelines,
Mhm.
let's say Rose's case, she didn't get Dex.
Yeah.
Then she still would qualify in the
Ventolin,
grade one.
yeah.
But like, if you look at CPS guidelines, like I just
I know.
looked at them just to make sure that
I know.
wasn't imagining, she should be on a SABA and ICS, not just.
I know,
And
but
I know that you didn't write these guidelines.
no, but this is INESSS, and they clearly say, well, I showed you the slide, that they accept that we use SABA alone is step 1 treatment. And so Lebaca, so they write that in adults and teenagers, you don't use the SABAs alone, but the SABAs alone, seuls en thérapie de secours, peuvent être utilisés chez les enfants de 11 ans et moins à l'étape 1 du traitement.
Regardless of the severity of her first exacerbation, unless she gets Dex.
Exactly. So if it's severe enough to get DEX, well, then you go up to moderate dose. But if you're not giving DEX, well, she's just on Ventolin.
And if she's at her 4th episode of reversible bronchospasm in your office, so she's totally well, so now she doesn't qualify for step 1 anymore. So at that point, you're going
Exactly.
ICS.
Exactly.
Continuous?
Absolutely, daily.
Continuous. So according to them, there's no intermittent ICS.
That's it. But they know we do it. And if you do it, it's 3 episodes in 1 year, no symptoms in between, and no systemic steroids in the previous year. So that's step 1 for them. Step 2 is the mild dose or the single layer. But there again, in step 2, you have a daily dose, but you haven't given systemic steroids in the past year.
Any comment on the duration of ICS when you're doing
We always, in asthma, we do everything for 3 months now. So we treat for 3 months and reevaluate. It's always 3 months. We do every step by 3 months, and when you see them, if they're well, like you started them off on moderate dose, they're well after 3 months, I come down to mild dose. If they haven't been well, then you have to step up. And the minute they have an exacerbation and you give systemic steroids, you have to step up.
Do you have a certain number that we can say to parents? You know, they're always worried about being on an inhaled steroid for long periods of time.
Yeah.
So I tell them that, 1 dose of oral steroids is the equivalent of thousands of doses.
Wha-
But is that just, am I
Yeah,
saying that?
no, we're coming to this is in the next slides. You're going to see that at the end I'm talking about systemic steroids. And so I just wanted to go back to where I was. And so I'm really going through the recommendations. I'm not going through what we do in respiratory. I'm just telling you exactly what they wrote down in this, because the pharmacists are going to follow what's written down here. And so Rose is back in daycare, and so she had this exacerbation in March. And now you have her on Alvesco 200, and she has another exacerbation. She goes to the ER, and she gets DEXA once again. And you decide at that point, INESSS says that you have to refer to an asthma center, which makes a lot of kids who are going to be referred. At that point, as you're not getting your referral right now, you're just going to say, I'm going to try single layer, and you add on single layer 4, which she starts in July. And so it's the summertime, she's breathing beautifully, everything is fine, but now she's not sleeping, she has trouble falling asleep, she has nightmares, she's very moody, and now she's hitting friends at the daycare. And so INESSS mentioned it, there are neuropsychological side effects with single layer, they're known. And we have to mention that these side effects are usually in the first 2 weeks of treatment, and after that they're supposed to subside. And so we really have to encourage parents to get by the first 2 weeks, even if it can be challenging. The second thing is if parents ever have a concern, when we discontinue the medication, it's documented reversible. So the nicest publication in pediatrics is Dr. Ernst's father and daughter, they're both respirologists. They published this in Pediatric Pulmonology in 2017. They say that the neuropsychological side effects are 12% of children. Usually you have it in the first 2 weeks and then they go away, but still 12% stay with the side effects. And when you discontinue single layer, everything goes away. And so this is what you're going to do. You stop the single layer, and the parents are very happy because now she's sleeping, she's happy, and she's no more hitting friends at the daycare. But you're saying, well, what do I do? She's on Alvesco 200, and she went back to the emergency room. And so this is something that really came out on Thursday, is that everybody says, well, she didn't do well on a moderate dose of ciclizumide. I'm going to try another type of inhaled steroid. And so we can all have our personal preferences of this steroid compared to another one. When a child is not doing well, we do have the option of saying, I'm going to try something else. And so you switch around to Flovent 125 twice a day. And you just saw her in September. It was the September peak. She had a URTI. She had an asthma exacerbation. The parents gave a bit of Ventolin 3 times a day for a few days, and everything subsided. And so her asthma is being well managed on Flovent. And so the key messages about the different inhaled steroids in children below the age of 5 is that we can have our preferences, but they're all equal. Where they're unequal are on the side effects. And fluticasone is definitely the inhaled steroid that has the highest systemic action. And this is why Lina says to be very cautious on what are the dosages we're using in young children. And so when I put a child on Flovent, we really have to keep an eye on the statural growth curve. And after 6 months of inhaled fluticasone, we do an early morning cortisol level to make sure that we're still above 275. And so below 100, we're in trouble. In between 100 and 275 is the gray zone. And when we do the early morning cortisol level, we have to stop all topical steroids the day before we do the level.
Stop again. Sorry.
Yeah.
But they're holding children on fluticasone to a higher standard than 2 standard deviations of the norm. So when AM cortisol in younger children is usually about 160 to 180, you can accept all the way down to 120. And for them, if you're on steroids, it has to be 275. And I'm not sure if that's part of the steroid effect.
But this thing at 275, I get that with endocrinology. These are the values endocrinology is working with in young children. They really went for the AM cortisone at 8 o'clock. When we have our burst, they would like them to be above 275. The lower values, they accept if we do it later. If we do it around 11 o'clock, well, then they're coming down. But they try to keep them. We have a lot of kids in the gray zone, and the endocrinologists say before the age of 5, they're not worried if they're above 200, but in between 100 and 200, they tell us to be careful.
How do you logistically get an 8 a.m. cortisol?
You really have to write urgent, and you write it has to be 8 o'clock.
Just mark it on.
Yeah.
Even on your lab, on Unimed, you have the option with the time.
Yeah. And so this is what INESSS tells us. And so what do we do besides referring them to an asthma center? What are our other options? In young children, there are 2 things we really have to do. We always have to check adherence because a lot of doctors prescribe as needed medication, and if not, a lot of parents do it. And so when the children are well, usually parents just discontinue. They don't understand that they have to keep on giving them an inhaler when they're doing well. This is the first thing. The second thing is that we have a lot of difficulties with the aereo chambers and the 5 most frequent mistakes. And so the 5 most frequent mistakes is that when we give the medication to young children, they always have to be sitting or standing. They can't be lying down. They can't be sleeping lying down, and especially not with a pacifier. So this is the first thing. The second thing is the aereo chamber has to be changed once a year. And so they often take the aereo chamber of the older brother and sister, but an aereo chamber is good for 1 year. After that, the internal membrane is no more good. It has to be changed. It has to be washed once a week. And most frequent mistake when they're washing it is we tell them not to dry it, not to wipe it, but what they have to not do is we tell them not to touch the inside because the membrane is very sophisticated. It's an anti-static membrane. And one mother that I just saw recently, they take the brush they use for the bottles and they brush the aereo chamber, but if you touch it, you break this membrane, and then the aereo chambers become white and you don't see through them because the medication is deposited in the aereo chamber and you don't have a bronchopulmonary deposition. And so these are the most frequent mistakes. And what we're seeing recently is that there have been budget cuts and the kids go to the emergency room and they get a disposable aereo chamber. That's only good for 10 uses. After that, it's no good. And even sometimes they use the mask that they have in the operating room that's very comfortable. So the parents really like these aereo chambers, but they're absolutely no good. They're comfortable, but they don't give a good deposition. And so just in the past week, I threw 3 away. The children were out of the emergency room and they've been using this for a month. These are really not good aereo chambers. We have to make sure they have the standard thing. And so the comorbidities that are typical in children below the age of 5, they're really 2. The first one is everything that's ENT, postnasal drip, sleep apnea, on enlarged adenoids and or tonsils, and there's the whole topic of microaspirations. And so this is a second message that exactly the opposite of what they say in adults. In adults, when they have reflux with asthma, they say you have to treat the reflux, and children will say you don't treat the reflux. And so what we do say in children is that you treat the respiratory symptoms first. If a child is not coughing and breathing properly, he's going to reflux less. The second thing is we have much more microaspirations on swallowing in young children than on reflux. And my most frequent mistake is we have to realize that these kids have been sick, the parents are tired, and they just gave in and they have a bottle of milk at night. And so my record at Tanitas this year is a 5-year-old with severe asthma that was still sipping on a bottle all night of milk. And so this is a bad habit that comes, and when they have respiratory symptoms, we make sure they stop this in between the ages of 15 and 18 months. And for the reflux, the reason for which we don't recommend to treat is you saw the statement of the Canadian Pediatric Society in November saying that we have to come down on Prevacid because it makes children more prone to viruses, and viruses are the major trigger of asthma in young children, so it doesn't make any sense. And we also have an increased risk of fractures that has nothing to do with asthma. And so what happens when the kids become sick? And so when they become sick, we have 3 different challenges. And so the first mistake we're doing is we're telling parents that children outgrow asthma and they're cured of asthma. And so this is not true. You know, asthma is really a chronic illness, and if you're asthmatic, you're going to stay asthmatic. There are going to be periods that are more difficult than others. There might be periods of time where they're taking minimal medication, but it's something that stays. And so what happens before the age of 6 is that in this group of children that we're treating as asthmatic, they don't all have asthma. And so we have the preemies that just have a very narrow airway, and they're just going to catch up with other children, and some will have asthma, but some won't. It's just because they had a narrow airway and they had difficulty clearing the mucus. We have the large group of ENT children who have postnasal drip, and they finally got to see ENT, got operated or not, and everything resolved, and they do not have any lower airway issues. We have the large group of children with microaspiration. I really find that we have a large group of children that just have mucus plugging. So they had a bad RSV, they stayed with subsegmental atelectasis, they have mucus plugging, very narrow airway, they can't clear it, and so they go from one exacerbation to another, and at the age of 6, there's really a growth of the airway, and they have an increased diameter, they can clear the secretions, and then they just do better. And there's an immune maturation at the age of 6, and so whether we do something or not, the risk of pneumonia just drops at the age of 5. And so what happens at the age of 6 is that they do better. The real asthmatics do not outgrow their asthma, and we don't see them as much because they're not sick as much, and the chief symptoms that appears is that they just can't run. You know, they're just out of breath, they can't do gym, they can't do sports, they're not comfortable doing sports because they're out of breath, and this is a symptom that we, you know, if we don't look for it, we're not going to find it in clinic. And so the other thing that's very important, starting the age of 6, and we can even use it lower, is that we now know in asthma that we have markers of inflammation. And so the main phenotype of asthma in children is what we call the T2 phenotype. In the T2 phenotype, you have 2 markers. You have the eosinophil that you really put in the center of this picture in the IgE. So I don't want to go through all the details, but what we know is especially the eosinophils. The eosinophils have a positive predictive value for an asthma exacerbation. And so a child who has respiratory symptoms who's eosinophilic, we know he's going to exacerbate. The high IgE level has a positive predictive value for responding to inhaled steroids, but especially the eosinophil, this is a clue that we can have that this child really has asthma because he has hot markers of inflammation of the T2 phenotype.
And so is your eosinophil count based on bronchial alveolar lavage or on peripheral blood?
Peripheral blood, and we have to do it in a stable state because whenever we're in the emergency room in any stress situation, the eosinophils just run away and we have a 0. And this is where I want to get to, is INESSS wrote it in the risk factors. And so when we start the age of 6 and we try to decide how we're going to treat an asthmatic, we have the severe exacerbation, but we also have another category. And they're asking us to try to identify in a child a risk for an exacerbation. And there's a whole list. There's some that they're obvious for everybody. So if a child is very symptomatic or the PFT is abnormal, everybody agrees that we have to treat. But there are 3 other criteria that are very important. And one of them is if a kid is using too much SABAs. And so to get back to the SABAs, the limit are 2 inhalers per year. It's very difficult because I try to write prescriptions, renewable
2 full MDIs
per year. Per year, that's it. And so I tried to write them renewable 1. I can tell you it doesn't work because the facts all come back and the pharmacy says we're out of Ventolin. When I see like 5 renewals in the DSQ, I try to tell parents you're buying too many Ventolin. They say no. The father has one, I have one, there's one at the daycare, one at school, one in the school bag, one upstairs, one downstairs. They have all kinds of excuses. But I try to tell them that we really have a limit because the limit for the SABAs are 2 inhalers per year and that's it. And the 2 other risk factors that are very important is any third-hand smoke is a risk factor for an exacerbation. Any allergen, when we know a child has allergies, if the allergen is there, it's a risk factor. And if the eosinophil count is above 300, it's a risk factor. So the risk factors are very important because they have a role to play in where we are to treat a child in the ages 6 and more.
All right, third-hand smoke is what again?
It's a risk factor for a severe asthma exacerbation.
hanging on
clothes.
fabrics and clothes.
Yeah, third-hand smoke, and they even vote, it's very interesting, they vote vaping and they vote cannabis. And so this is important because you're going to see it further. If a child has one risk factor, they automatically recommend daily inhaled steroids. And so if you have a kid that has very mild symptoms, you said he gets sick twice a year with a cold, but he's allergic to a cat and he has a cat, daily inhaled steroids. If you have one risk factor. So this,
The eosinophils, like, is there, because that drastically changes management, because if they have none of the other risk factors and they have the eosinophils, but, so is there an indication to be doing blood work, like, on?
yeah, well, we do it. We do the CBC and the IgE level because the markers of inflammation in asthma.
From the get-go?
And so because if you have like an eosinophil count above 300, you have one risk factor of an asthma exacerbation. So even if a child has mild symptoms, they're going to tell us to be step 2. We're automatically step 2 if there's one risk factor. So this is where they're heading to. And so,
So you'll do it at baseline?
Yeah.
You won't monitor it necessarily? You won't use it to see response?
no, at baseline, really at baseline. And so the diagnosis of asthma in children beyond the age of 6, the only thing they're saying is that it requires PFTs. And so we cannot treat a child 6 and above on a convincing report. They say you can initiate a treatment on a convincing report, but you have to get PFTs. And so there are 3 things that we can do in PFTs. And so at baseline, what we do, and we can do a talk only on PFTs, but at baseline we do the spirometry, and we check if there's a response of the FEV1 to bronchodilators. And in children, actually, I had to tell INESSS to correct the report, and so they wrote that we need a response of 12% and 200 milliliters. This is not true. In children below the age of 12, it's only 12%. But now they corrected it and they made another mistake and I didn't write them back, so maybe you can write to them. And so now they wrote in the report that the 200 milliliters are for adults, but it's not true, it's the age of 12 and above. And so below the age of 12, it's only 12%, and beyond the age of 12, it's 12% and 200 milliliters. And when we calculate it, it's not a subtraction, it's really a delta. So we take the absolute value of the FEV1 and we do the post minus the pre divided by the pre, and if you have a delta of 12%, it's a significant response and it's diagnosis of asthma. The second thing that we're allowed to do in children is that if we do a baseline spirometry and it's normal and we're convinced that this is asthma, we can initiate treatment and 3 months later redo the spirometry and calculate if there's 12% in between both spirometries. But the limits of doing this is that there's growth, and with growth the values change. And so it has to be 3 months, it can't be more than 3 months, and the minimum has to be 1 month. And so we can't.
It's normalized for height.
Yeah.
So
Yeah, but we calculate the delta in between both. And so we take the absolute value of the 3 months one minus the one before, and we divide by the one before. So we do a delta in between 2 spirometries.
I hear you, but they're still normalized for height.
But we're taking the absolute value.
I see. Okay.
So like we're not taking the percentage, so we're taking the absolute value. So if you're taller, you just have a higher volume, but this is not an asthma response, it's just because you've grown. But we do a delta in between 2 visits, but you have to block this at 3 months because beyond 3 months, there's an element of growth that's going to change our values.
Sorry,
Because
is it 3 months or 4 weeks?
the minimum is 4
4
weeks.
weeks or 3 months?
And the maximum is 3 months. You can't do it beyond 3 months. And the last thing is to find a methacolin challenge. And so I just want to review a few cases.
So you do a delta
Yeah.
of a delta already?
No, we do a delta in between with 2 different testings. So we take the testing at 3 months and we compare it to the testing.
Pre or the post?
We use the pre at 3 months and we compare it to the pre 3 months prior, and we do the delta and we see if we have a 12%. And so I see a lot of kids who have 85. We treat them and they come back at 110. So they obviously have asthma. Under treatment, they really increased. And so this is something we do because we have a lot of difficulty getting the methacolin challenge. So I just want to show you a few cases for the PFT. And so this is Dylan 6, and he didn't improve. And so he had actually recurrent mild fevers and recurrent illnesses, and he was undergoing a full investigation, and we just did this PFT. And I just want to show you, it's not going to enlarge anymore. Sorry, it was working before.
I was going to say try Control plus plus, but I
I'm
don't
going
think
to
that's
lose
gonna
everything.
work on that, 'cause
We
we're
just-
presentation mode.
Yeah, I can do it. Sorry, I could do it before, but it's not working anymore. Nevertheless, the VMS is the FEV1, and so we see that he had 88%, and we just gave him, I had it down here, and so we calculated the delta, and he only has 170 milliliters, but because he's 6, he has a delta of 14%, so his diagnosis of asthma. And so it doesn't enlarge. And this is another one, Samuel, who came to us and was very interesting. And so Samuel, he was just out of breath, and he was trying to tell us that he was an artist. He was just not good in sports, and he just wanted a ticket for gym because he had a difficult gym teacher, and he had to do the beep beep test. And he says, I don't know how to do this test. I just want a ticket because my teacher's too difficult with me. And so we really have, I think in this clinic, we do PFTs, and any kid who was short of breath, and he really had asthma. So we didn't give him any ticket for gym. We just gave him a plan of treatment for asthma. And he had 12%, but he had more than 200 milliliters of improvement. And so this is Anna, and Anna, she was very funny. She only needed Elvisco fall and winter. The rest of the time she was not asthmatic. And the parents were very happy how things were going with Elvisco because she only had coughing. And as we reviewed the chart, we picked up 2 things, is that she had 1,700 eosinophils, which is very, very high, negative allergy testing. And we tried to do a spirometry, but she was blowing 120%. And so we reviewed the chart, and she had 3 right middle lobe pneumonias. We did a chest X-ray, and she had right middle lobe disease. This was well investigated, and she had no obstruction. She really had only eosinophils, and she finally got a methacolin challenge, and she's really positive. She was actually reacting at 0.3 milligrams. And so we had a normal spirometry at 120%, but a very positive methacolin challenge. And the parents have picked up since then that she has asthma. She needs routine treatment, not only treatment from September to April. And so,
I have a lot of problems
Yeah.
with the eosinophils testing, because we have a lot of kids that have eczema, they have like all sorts of allergies, food allergies that grow, and it's not unusual for them to have like more than 1,000.
they have to also have respiratory symptoms.
Yeah, but a lot of them do. They go to
I know.
daycare, they all have colds like one after the other. So I think it's very tough to use it as one risk factor.
Yeah.
To decide we're going to treat a lot of more kids
Yeah.
with ICS.
Is the eosinophils for the more than 6 or for the more?
Eosinophils more than 300.
No, sorry, more than 6 years old?
Yeah.
Mostly, okay, so at least it's like not.
Yeah. It's beyond the age of 6 that they put it as a criteria. They didn't put it as a criteria on the young children.
So as per these guidelines, basically we should be doing a blood test for every asthmatic
Beyond the age of 6.
beyond the age of 6, and also referring to allergy off the bat, or just if we have a suspicion?
Only if you have a suspicion. But they really recommend to do the CBC and the total IgE beyond the age of 6 because especially the eosinophils is a criteria.
6
In
and
the-
up only.
6 and above, so it's not below 6. Yeah.
I don't know, for Alvesco, if you want to give a young child under 5, 200 micrograms a day, I don't know if you mentioned, is it better to do 200 micrograms all in the evening with a 200 microgram inhaler, or do a 100 microgram inhaler, 1 puff in the morning, 1 puff in the evening?
Okay, cyclisonide is really 24 hours. It's better to give it in the morning, and it's better to give 1 puff of 200. which is the moderate dose,
So the morning is better than the evening?
really, before activity. So we give it in the morning, 200 micrograms, and we give it daily. We have actually a better adherence with daily medication, and ciclizumab is really a 24-hour molecule. So in the children below the age of 5, the molecules that are twice a day are beclomethasone or fluticasone.
Also, for the test, because we always have to do a pulmonary function test since it's very difficult to get it.
Yeah.
And especially at the hospital. So I totally have it because we're so lucky to have you. So we can just like send them to you. You do it in the office.
Yeah.
But do you recommend that we send like automatically, directly for spirometry in the office? Is it
Well,
equivalent?
Well, we have to do spirometry, and once we have a diagnosis of asthma, the recommendations is to repeat it once a year. So we have to do follow-up.
Once later and once a year.
So we do it at diagnosis. We do always a follow-up after 3 months and after 1 year. And if they're not doing well,
How practical this is going to be, like for like to follow up our patients, like if we don't have you, like for all
Yeah.
the others who are following the guidelines.
well, the real thing about PFTs, and this is a bit why we try to create a lab in Quebec, is the real, for spirometry, the age that 50% of children can do spirometry is 4. And we have the predicted values for the age of 4. And it is 50% of kids the age of 4 that are able to do a correct spirometry, and we really reach the criteria of ATS. And now we have the oscillator, and especially Dr. Duchamp, she just published the normal values for the oscillator. And actually, I'm going to get it. I was supposed to pick it up. I'll pick it up another day. We're going to have the oscillator here too, and the oscillator is much easier. We can go all the way down to 3, but 3 and 4, you still have 50% that can do it. But the difference with the oscillator is that they're just breathing a tidal volume. And so there's still a mouthpiece, and there's still a nose clip, and I think there's always going to be a mouthpiece and a nose clip in whatever we're going to do, but they have to breathe. They don't have to do a big inspiration and a complete expiration. And the way we get them to do a breathing test at the age of 4 is we have games, and so they just want to play the game. We say you have to pop the balloon, you have to play the game, and so they really, the 4-year-olds do it beautifully. And so I just want to show you, this is Ma, and she was 4, and it was actually a pediatrician who saw her, and she said, she really doesn't need you. She had COVID, and she's been coughing since COVID. Mom has asthma. She had a ton of eczema. During the pandemic, they got a cat because they were all stressed out. And you don't see the PFTs, but you know, she had an FEV1 of 85, and after Ventolin, she had 114. Her delta was beyond 30%, and so she really had asthma. And since then, she's been on a plan of treatment, and then she comes back to us. She has 100%, and we have no response to Ventolin. So now she's waiting for methacholine challenge because we're trying to figure out, is it just a post-viral asthma, or is it a T2 asthma? Her markers are cold. She still didn't have allergy testing, but her marker, she didn't have any eosinophils or any high IgE. If the methacholine challenge is positive, well, then we'll go further.
And she was treated with Lavesco 200.
Yeah. And actually now they brought it down because she's well. So they brought it down to 100. Her PFTs are normal. She's doing very well. And she's waiting for a challenge. And so in the children more than the age of 6, when we go through what they call the critères de maîtrise, we really have to look for 2 of them. We have to look on how much SABAS they're using. This is really important, and how they're doing on exercise. These are the 2 most important, because le débit de pointe, the peak flow, we don't use anymore in children. And they write it, they use it in adults, but it's no more used in children. The eosinophils in sputum, we absolutely do not have in children. And so there are a lot of criteria that we don't have. And not going to school, we all know that if kids are sick, they go to school and they go to daycare. And so we really have a difficulty with the other criteria. And so we have to outnumber how much Ventolin they're using and how they're doing on exertion. And as I said previously, we're going to get back into this. And so if we have one risk factor, you're going to see what's coming up on the levels of treatment. And so for children above the age of 6, and so we're talking about the 6 to 11, and actually they put everybody in that group, but for children above the age of 6, step 1, they have to have symptoms less than twice a month. And so if you want to use Ventolin alone, because they're short of breath on exertion, the limit that they put is twice a month. And so they're really narrowing it down to patients that we don't see very often. And to be at step 1, you have to have 0 risk factor of a severe exacerbation. The minute you have 1 risk factor of a severe exacerbation, well, then you have to go to step 2, where there's a daily dose, a daily small dose of inhaled steroid. And so they're saying, yes, you can give only Ventolin in children, but they give us criteria that we're not going to be able to find any patients that meet these criteria. And so to be with Ventolin alone in a child below the age of 11 is not more than 2 use per month. And so it doesn't even meet gym classes. And they have no risk factor. And so no smoking, no allergies with a pet. The minute we have one risk factor. And so step 2 is very important. As I said previously, if they have very mild symptoms, but they have a risk factor, you have to give them a daily dose of inhaled steroid. And so this is how they put it, starting the age of 6. And so for children 6 to 11, what I really want to outline, because this I find very important, is that at step 3, which is moderate, they really allowed us to introduce what we call MART and SMART and what we're using beyond the age of 12. And so at least we got this starting the age of 6. And what we call MART and SMART, this has changed often. Initially, SMART was single medication asthma regulation therapy, and that has been completely changed. It's single maintenance and rescue therapy. And so it's just one single medication as maintenance and as rescue therapy. And why do we say SMART and MART? SMART is with Symbicort, MART is with mometasone, which is Zenil. And so we're doing this distinction so that people say, if we say SMART, well, we're using Symbicort tubular. If we're saying MART, it's because we're using Zenil with the aereo chamber. But at least at step 3, and when we use this, is we only give the patient one inhaler. They only have Symbicort or they only have Zenil. And if they have more symptoms, they can take it more frequently during the day, but they don't have any backup. They don't have any SABA. And so this is what was important. And the dosages, I have to go through the dosages in between children 6 to 11, because what they call the low dose is what we call the moderate dose in young children. And so the low dose of cyclizonide Alvesco in a child starting the age of 6, the low dose starts at 200. And so, you know, they really brought up the dosages. And cyclizonide, actually, they brought it up all the way up to beyond 400 micrograms. I personally never prescribed dosages like that on a daily basis. And what we have to know in children beyond the age of 6 is that we now have 5 inhalers. So we have the 3 same inhalers that we have below the age of 5, but we have the dry powders. And the 2 dry powders that we have available is mometasone, which is Asthma, and we have 3 dosages, 100, 200, or 400. And we have Pulmicort that we've had for a very long time. That's also in 3 dosages, 100, 200, and 400. However, they did put that the mild dose of Pulmicort is below 400, moderate is in between 400 and 800, and high is beyond 800. There's something else that's very important when we're treating children is that we do have environmental issues, and I'm sure you've already heard about this, is every time we prescribe one inhaler of 200 dosages, is the equivalent of doing 290 kilometers by car as a green gas effect. And so they tell us at the age of 6 that we should try to switch over children to dry powders. When the adults talk about this, they say, well, the best inhaler remains the one the patient is going to take and the one that the patient likes to take. But we have to take into account that there's a lot of pollution. So the asthma medication are responsible for a significant amount of the pollution that we're doing in healthcare, and they're asking us from the age of 6 to try to change them. I do this all the time, and we really have to always recheck how a kid is using the dry powder, because the main problems I have is very frequently the parents are too much in a hurry. They're not watching the kid taking the dry powder. And when the kids take the dry powder, they have to realize that they have to exhale, then put it in their mouth, inhale, and keep their breath in for 10 seconds. So this is challenging. The other thing is they really have to put their teeth on top of it. And so what kids usually do is they put the teeth behind it, so they're not taking any medication at all. And the other things they do is they're very good at going and so they have a very high oropharyngeal deposition, and this is not going at all to the lower airway. And so we try, and so we agree we're going to try to switch them over to dry powder. The other things that we have to be doing, kids are very severe when it comes to environment, but if we're not comfortable with the way a kid is doing, well, then we don't switch over to dry powders.
Priscilla, sorry, has anybody tried to gamify the dry powder inhalers in the same way you've done for the reverse for PFTs as a training device?
Yeah. Well, the one I really like is the Breeziller from Atectura, and we only have it for 12 and over. And what we like with the Breeziller is that it's a dry powder. It's once a day. It has a 24-hour action, and when the kid takes it, it's a capsule. And so he tastes it. It has a taste of lactose. And when he's inhaling it, we hear it. There's a vibration. And if we don't hear the noise, well, then he's not taking it. And then we open it up and we check if the thing is empty. So this is one of my favorite inhalers, but it's only authorized 12 and over. But if you listen to the adults, and this is the end of the talk, the adults are really heading this way. And what they're saying is they're saying we have to rethink asthma. We have to just see asthma as a chronic disease. You take a medication in the morning and you're set for the whole day. They do a comparison with hypertension. They say people don't take a pill because they're in traffic, or they don't take another pill because they have a meeting. You know, they take a medication in the morning and it's for 24 hours. And so what they like with Atectura is that they take it once in the morning. It's a dry powder. It's 24 hours. And when you use, it's mometasone also. Respirologists like mometasone a lot. And so it's mometasone, which is a good inhaled steroid that we know very well, and it's indacaterol. Indacaterol is a 24-hour beta-2. And so they use very little SABAs, if any. And we have three ways of checking how they're doing it. And this is something we do in clinic. We have them use the tubular. We're not sure. They use the breeziller, and it's all wrong. And so we know that when they're using the tubular, but if you listen to the doctors in Ontario, they're really into the breeziller because of the way we can check how they're doing it. If not in clinic, I have the whistles. So with the whistles, we can check how they're doing it. But when they're taking the real dry powder, I have no way of checking how they're doing it.
Just a small programming note for turbuhalers.
Yeah.
Smart therapy or terbinafine, terbutaline.
Bricanil, yeah. But it's Italian, that's correct, yeah.
So if you breathe in too hard, then you will make a noise, and you're also again going to get the wrong deposition. So whereas that other inhaler for 12 and over, the noise is comforting. It's
Yeah.
telling you you're getting it just the opposite. If you're teaching in the office and you hear a noise,
Yeah.
you breathe in too hard, and they're not going to get deposition in the right place.
Yeah, and when we use the breeziller, they hear the vibrating sound. But in the adults, they're using a lot this breeziller. That's 24 hours, once a day.
I just have another
Yeah.
question. For the 6 and up,
Yeah.
do you go right away to SMART or MART instead of like prescribing Ventolin?
Step 3. Step 3, yeah,
Oh,
moderate.
Step 3 only. Okay. So
Yeah.
because there's still space for Alvesco and Ventolin PRN
Yeah,
if they're not step 3.
exactly. And we have the other. So we have 5 inhaled steroids. We have Cuvard, Alvesco, Flovent, Asthma-Nex, and Pulmicare. We have 5. And when they go to step 3, well, then you can use the combined medications, Symbicort and Zenil. Only one was step 3. I use a lot of Zenil, but I'm really saying only what INESSS says to do. I'm really sticking to the message.
Because we have younger children.
Yeah.
often have.
Well, honestly, what I see in the office, and I see this all the time, you have a lot of children that come from backgrounds that they don't understand what they're saying. They don't see the difference in between orange, blue, when do you use blue, when do you use orange. So I had the father the other day, he just arrived in Quebec City, and he says he's sick because of the winter. No winter, no sick. If this winter he's sick, and he knows nothing else about asthma, so the kid is answering me. So we'd really say, you have one inhaler, 7 o'clock in the morning, 9 o'clock at night, he has a cold, 7, 11, 15, 19, we write it down, 1 puff. They can't follow us when I say there's orange, there's blue, you go up. We have to simplify.
Not talking about the colors of the air chambers also, like you said to change, but
Yeah, so we really try to be simple in our message when we have difficulties, youth protection, les milieux vulnérables, but INESSS is really doesn't agree with this, and so we stick with 6 and above, step 3. We can use MART and SMART. Step 1, step 2, you always have single layer, but you have 5 inhaled steroids, so it's the 5 that I named before. Yes, I'm listening.
Are you also finding in the lab when you're doing pulmonary function tests, are you finding a lot of non-conclusive tests because the
True.
patient is not able to cooperate well enough and do
So this is why we're getting the oscillator. There's a significant amount of children, especially with neurocognitive disorders, that cannot do a PFT.
Or I would just find even like these anxiety or just their effort, like even, auscultating lungs for 30 years, kids don't take breaths
Yeah.
the way they used to 20 years ago. They can't take a good breath. They
Yeah.
don't know what to do.
But I think when we do PFTs now, we really have games, and so they really want to play the game, and it makes it fun. They just have to pop the balloon, and we have like 20 different games.
Okay.
And so I think they see us like something fun. They don't like the nose clip, but not too bad. But there's always a group of kids who cannot do PFTs, and we have the criteria. They have to have AA, and if they don't meet the criteria, well, now we're going to have the oscillator. That's much easier.
What
And
does
so
that look like?
The oscillator is a very, I had a picture, but I didn't put it. It's just a small box that we're holding for them. There is a mouthpiece, so they have to take the mouthpiece and they just breathe normally. And it's very short. So they're breathing tidal volume, and it calculates the resistance.
Sorry.
And we calculate the resistance, and then we give Ventolin, and we calculate if the resistance is lower.
And what's the wait time to get that?
Well, the only place that has the oscillator now is the Saint-Justin. And the wait time is very long, up to 2 years, but we're going to have it at Tiny Tots. I just have to go pick it up. I'm not ready, but I'll be ready soon. Yeah. And so I get this set up in I have these resources in Quebec. I get things set up, and I put them in a bag, and I bring them to Tiny Tots. It's good, no?
Oh, yeah, that's great.
When we have, let's say we send a patient to do PFTs, okay, let's say we can't have them see by ear or whatever, we send them. Is there a difference, because in adults, like I was told, if I send for spirometry versus just sending for PFTs, it will go faster. Obviously the difference is that spirometry doesn't have the interpretation, we interpret it ourselves, and I think it doesn't have the DLCO, but I don't know really why I use that. So I can just send for spirometry, or I have to send for PFTs, like when I send, and where would I send?
You can send them just for spirometry. You can ask for methacholine challenge. You can send them for whatever you like. But what I've had...
Spirometry versus littéralement pulmonary function test.
Oh, in asthma, you just need spirometry, or you need methacholine challenge.
If I just do spirometry
Yeah.
versus full PFTs?
Yeah. Yeah, because the lung volumes, it takes 1 hour. It's a much more challenging test. And it's the test that the kid has to enter a box, and we close the box. It's much more difficult to do plethysmography in children. And it's a 1 hour testing. And so if you ask for full PFTs, it's longer. We do it sometimes when we want to check if they have a high residual volume. But most frequently in asthma, we try to do just the spirometries and the methacholine challenge. If we're going to use 1 hour of lab time, we're going to do the methacholine challenge.
You still using methacholine or mannitol?
Well, mannitol is for exercise-induced asthma. And the problem with mannitol is that we can miss some children, and so we can have a negative mannitol in an allergic asthmatic, and it's not. And also, it's a powder, and so they're starting around the ages of 8. With the methacholine challenge, we can start at 4.
And for children, it's all coming back as mannitol.
Yeah, because they're doing mannitol because with COVID, they don't want any aerosols. The mannitol is a powder, and they don't want to do, when we do the methacholine, it's really aerosols. And with COVID, they have such complex children, they don't want to have any aerosols in the lab. And so they even, I don't know if they stop, but they do COVID testing prior to our child entering the lab. And then they do the testing, but they really, with the, I think it's really the complexity of the patients they have at the children's. They don't want any aerosols, so they switched over to mannitol. And I think so 3 years down, we're still with mannitol. But they write down in the report that this is specific for exercise-induced asthma, and if it's an allergic asthma or something else, they can be missing out a kid. And it's a dry powder, so I sent some kids that really couldn't do this. It was more difficult. It usually starts more around the age of 8. But it's to avoid the aerosols. Yes, I'm listening.
Do we have anywhere those criteria that you wrote that bring
This
us
is
to
INESSS.
level 2, like the increased eosinophil count, having a pen
Yeah.
at home, having some...
This is INESSS. This is INESSS. It's online. So you type INESSS asthma September 25, 2023. This is l'outil clinique. These are the slides.
Could I just ask you, what would be your interpretation if a patient, a teenager who has
Yeah.
asthma, is stable with all those criteria, but when they laugh hard, they start to cough and wheeze?
Okay, so this is non-controlled asthma.
What about if
Kids
they
are supposed to be able to run, laugh.
Right. What if they just tell you that sometimes if they laugh, if they just go, like I've seen some asthmatics telling me, well, I can make myself wheeze if I want to.
Okay, so do PFTs. Yeah. When I have these things, I said, okay, I'll see the PFTs. And this is what they do. They come in, they have all kind of complaints, we measure. And this is the way we're going, especially starting the age of 4 and above, we measure. And so in this we talked about 6 and above. And so I have to talk about systemic steroids,
I
yes.
just have a really quick, I may have missed it, and I'm just trying to categorize, because I know like the GINA and the CTS guidelines talk a lot about like mild intermittent asthma, and I don't know if it's out of the scope of INESSS because they seem to categorize from the more severe.
They just don't want us to talk about
Okay.
mild asthma anymore.
Okay.
they just told us to not talk about it anymore. And these are the well, we'll get to these messages. There are a few key messages at the end. And so we have to talk about.
By the way,
Oh, cool.
on the ENS app, it's already up.
Cool.
And so for the systemic steroids, and so Gina brought this forward, and they talk about it also at INESSS, is that if you take systemic steroids, a short course, 4 to 5 times in a whole life, as an adult, you had increased risk of diabetes, osteoporosis, and cataracts. And this is the beautiful publication that was actually back in 2018, but it only came up in Gina in 2022. And what they say in this publication is we're talking about prednisolone. And so they say never to reach the dosage of 1,000. At 1,000, your risk of diabetes, osteoporosis, and cataracts is very, very high. And try not to go to 500 milligrams, but this is total lifetime. And so this is going to be my response to INESSS. I really think that in children we have to have a way of documenting how much dexamethasone we're using, because this is the graph. When we prescribe dexamethasone, to know how much prednisolone is, we have to multiply by 7. And so when we're giving 8 milligrams of dexa to a kid, it's 56 of prednisone or pizapred. I've seen in charts here 16. You know, 16 is a dose that we use in reanimation, but we're beyond 100 milligrams of prednisolone that we're giving to a child. Even if we're giving 11, because we're counting for the weight, well, we multiply by 7, so we're close to 80 milligrams of prednisolone. And we're giving dexa, like we can see Rose, you know, she had it 3 or 4 times going to the emergency room, and we have to start keeping track. And so our response is we need documentation, because the kids are not admitted to hospital. So we have no feuilles sommaires, and because they don't go to the pharmacy, we don't have it on the DSQ either. You know, they go to the ER, they get the DEXA. Parents are very tired. They didn't see exactly what happened, and they especially don't know what dosage they got. And so we need a way of keeping track of how much we're getting. And this is something that I'm starting to do in charts, is calculate and say, well, you know, your kid is 2, and at the age of 2, we're at 330 milligrams of prednisolone that your child has already received. And in his whole life, the publication says not to go to 500 and even to 1,000. And for me, this has something to do at where I am in the level of treatment, not to always give this dexamethasone. And so this they take back, and I absolutely have to talk about the teenagers, because the minute a child reaches the age of 12, the message is completely different. And so we're no more, it's no more recommended to use SABAs alone at all in no situation, and they really recommend to use combined therapy. They combine inhaled steroids and formoterol. It can be smart, it can be MART, but you can see that steps 1, 2, and 3, you're always with combined therapy. And so every time a 12-year-old takes any bronchodilator, there has to be inhaled steroids. And so INESSS says the same thing as the other guidelines starting the age of 12. It's just for the children 11 and below. They gave in and said, we're not going to go this way, except at the age of 6, we can do it when we're step 3.
Why should they not just take Ventolin?
Okay, and so Ventolin, I'll get back to this. And so why not treat with SABA alone? And so these were the GINA guidelines in 2019. And to them, Ventolin is one of the worst medication. Even after taking it for the first few days, you really have, it increases the reactivity of the airways, and it's associated with more severe asthma exacerbations. And so the way GINA is going is they're actually trying to remove, we can say there are 5 problems with Ventolin. The desensitization, the more you use it, the less, and I've seen so many kids here, the parents have been using so much Ventolin, they say it doesn't do anything anymore. I said, I totally agree, it doesn't do anything anymore, it doesn't work anymore, you've overused it, that's the first thing. So it increases the likelihood of having a severe exacerbation. And I think the huge problem we have with children is, so if you're 12 and over and you have an asthma exacerbation, you go to the ER, they give you prednisone or Dexa, and they give you Ventolin, you leave, you have a prescription of Symbicort. But if you're a kid, well, then you're in the ER, there are no RTs, now it's interesting, the parents are giving the Ventolin, and you leave the ER and you have a prescription of Ventolin. Do you really think that parents are always going to the ER when there's an exacerbation? I question them, and they tell me, well, you know, we give a bit more at night. Well, how much is a bit more? How many puffs are you giving? And I think there's going to be an accident sooner or later, because this is what we're doing in the ER. We give Dexa and we give a lot of Ventolin, and we say, here, go back home with Ventolin. And the parents say, it's the same thing we have at home. Are we going to spend 24 hours not be at work, not going ahead with our own lives, and we have the exact same medication? They don't have this issue at 12 because we don't give them a prescription of Ventolin, we give them Symbicort. So if they're in trouble, they go to the ER and they get the Ventolin, but then they don't have it back home. And so GINA for years has been heading to removing Ventolin, and Sarah says you prescribe a lot of Zenel. I was going that way. I was actually heading at using, they didn't invite me at INESSS, and they say you prescribe a lot of Zenel. I was going Mart and Smart. I do a lot of Mart and Smart, and the less Ventolin. I try to remove and put it renewable once, and try to be careful with Ventolin. I personally think there's going to be an accident. Because
they're doing exactly the contrary because they want us to use Saba alone.
yeah, step one. And so, but I have to go along with what Dr. Jam and with Sophia. They're the ones who are on the panel, and because these recommendations, we have to understand that the pharmacists are going to go by this too. You know, it's a whole group in asthma. So when I send a prescription, I prescribe Zenel. They're saying we refuse to serve the medication. So I have to write pneumology pediatric, patient d'exception. You really have to fill in something, or they won't serve the medication, and they really go by this. So it's going to be more difficult. Yes, I'm listening to you.
If I have a patient over 12 that's
Mhm.
on Symbicort,
Mhm.
and I've started with 2 puffs twice a day, and now we're down to 1 puff twice a day,
Very good.
and the patient comes back a few months later and they have no symptoms, what
'Kay.
criteria should I use between just removing the Symbicort and switching it to a PRN, or keeping them on something and thinking about maybe just Alvesco instead of Symbicort?
Okay,
to have a
and so,
better
well, first we
protocol?
need PFTs, especially in teenagers, because our values are not very good. And so sometimes they come in, they're doing great, but the numbers are terrible. And so the conversation is very short. You know, they see the RT, she does the PFT. I'm doing fine, I have no symptoms. I saw one yesterday. His FEV1 was 65. So, you know, the conversation is very short. I really think that we need PFTs, we need numbers, because it changes completely our perspective in clinic. That's the first thing. The second thing is that they don't recommend using only Alvesco. And if you're only going to use 12 and above an inhaled steroid and an as-needed SABA, you really have criteria. You have to be convinced about adherence. The teenager has to be perfectly well, no exacerbation in the 12 previous months. If you have those 3 criteria, you can do it. But the first criteria is you need no more PFTs
Do you want to do the PFTs on the Symbicort or on nothing
on the Symbicort.
to see if you? If
They
you
don't
can
take
stop?
it the day of the clinic. And so when they come for clinic, they don't take it. They take it when they're with us, and we check the technique. Because we can use formoterol to do the PFTs. And so we do the spirometry, we give them the Symbicort, and then we redo the spirometry. We wait for 10 to 15 minutes. And
I
I-
only select PFTs on the requisition. What do we?
Spirometry.
Anymore? Okay, and the wait is what, 2 months now?
I don't know. I'm not good in that.
2 years. Help us.
Yeah, but
Multiply
we,
times 7.
Yeah, because I have a patient that I saw today, and we'll come back in December and we'll decide, you know.
we do the spirometry here. I can do the spirometry. I don't know the schedule. I'm really not good in time, but we do the spirometry here, and I'll be getting the oscillator. But I really see, because I see how I do it in Quebec. You know, in Quebec we have the RT. She does 20 spirometries a day.
So can you get us a pharmaceutical company sponsored RT?
Can you bring it in your bag?
I don't know. But at this 30, he just took the Tamatar. He just took his. He just retired. He also has an RT, and she works at the children's clinic also. She works with the immuno, and it's Novartis who's backing her. So they have an RT at the children's clinic. But I really think it's the key, you know, because it changes completely the way you manage asthma, and you have a lot that have these symptoms, and you don't know what to do with the symptoms. We really look at the numbers. I had the other day this asthmatic that had so many symptoms. She had 130 FNFV1. I wasn't listening. At 130 FNV1, I'm going to wait for methacholine challenge. I'm not going to treat. But she had symptoms of severe asthma. It was really terrible. It was laryngeal dysfunction. So the numbers really change everything. And so really, I think, and so I see it because, you know, they come in, they do the PFTs, and I see them after. And I always have the PFTs, and I always have the questionnaire, and it changes completely the perspective of treatment. And I see a lot of young adults that do not have many symptoms, and they have very terrible PFTs, and they're not very symptomatic. And so if they're coughing and wheezing when they're laughing, that doesn't sound good at all. I would really do PFTs. And I think we have to get organized. What Dr. Shum wants to do is she wants all the clinics to have the oscillator. She finds that the oscillator uses less human resources, it's easier to use. And I think where they're heading to is that you don't necessarily need an RT to use it because it's really friendly use, and it's Larry Lance who's working on the software, and it's really user friendly. And since we're having such difficulty with spirometry is very technical. Like Livia's been doing this for decades, but the oscillator is much easier. So I think the next recommendation is to do the oscillator, at least to make sure that the resistance is normal and you have no response to Ventolin.
We'll
Yeah.
let you go on. Because
No, it's okay. I wanted to finish with the 12-year-old. I was just mentioning the two key things is that they're on MOT and SMART. And the other thing is we talked about the breeze alert and the whole concept they have in adults of doing a daily treatment less we're doing in any other chronic issue. And so those were the main things. I was really trying to stick to the message of INESSS because I think this is going to come up. It's going to come up sur le terrain at the pharmacies in the discussions with other clinics. And INESSS really asked us, it's a huge project, and they're really asking us to refer to this. It was very difficult on Thursday because the adults don't agree at all. When I was talking about sabazalong, they were just saying, no, don't say that. Anyways, but we have to
Because
stick.
they drilled in our head and increased mortality.
Yeah.
And not to do it.
Yeah, I know.
It seems like we really have to work on the emergency rooms because the DEXA in the emergency rooms are unbelievable.
But this is what we're going to be asking. We have to write it down somewhere, how much Dexa. I think when we give dexamethasone to a child, and I tell parents now because they call it the magical syrup, I said, well, your magical syrup is associated with adulthood diabetes, osteoporosis, and cataracts. And so then the parents said, we don't want it anymore. I said, well, if you end up in the emergency room are like fire people. They have to stop the problem. They're going to give Dexa and Ventolin. This is what they do. So what we have to do is make sure it changes things. Like a lot of parents don't want to give the inhalers. They just go to the ER, pick up Dex, a bit of Ventolin, they go back home. And then when you start talking to them about the side effects, they're more adherent to the regular inhaled steroids. Especially if they're on Elvisco, I said there are just about no side effects with this medication. And you're not giving this and you're giving Dexa. Your kid has had Dexa 4 times this year.
The other thing is that I find with croup, it's so overused. You know, oh,
Yeah.
can I just have a prescription on file in
Yeah,
case, you
8
know,
times.
or just because there's one barky cough, like they want their steroid. Like I'd rather
say-
come back tomorrow.
So croup, you have 4 things. It's always the triad, postnasal drip, asthma, and reflux. And so we first try to treat the postnasal drip, and if they have recurrent croup, some of them do have asthma. The other thing that if you want to replace Dexa is there's a nice compressor that you can order online, and they just use Pulmicort for 3 days. And Pulmicort is sometimes hard to find in the pharmacy. It's been among...
At 2,000 mics or something,
We-
much larger than what we're used to.
They went all the way up to 1 milligram, but in young children, especially below the age of 5, I use 500 micrograms twice a day for 72 hours, and it works beautifully, and we avoid the Dex. And so there's a very small compressor that you can order on Medline. It's very small, it's about $75. And the kids who have recurrent croup, I tell the parents, well, you check postnasal drip, asthma, and reflux. And then when we have the croup, they said the minute it starts, give them Pulmicort and keep on it twice a day for 3 days. And very often they get by with the cold humidity and they avoid the Dex.
But also, can we give now? I think I heard one of the respirologists saying 0.15 milligrams per kilo.
For
And that,
they're trying to come down, but right now it's for asthma that we use lower dosages, and in the last recommendations for croup, they're still at 0.6. But you
I
get
don't think
very,
they said it was official. I forgot who it was.
but you get very rapidly. We have to talk about the maximum dosages. I stop at 8. The ER stops at 10, and so comes a moment we have to stop counting because we're counting on milligram per kilo, and so we have to stop. I usually stop at 8 of Dexa. I find it's a big enough dose of Dexa. For a young kid, it corresponds to 56 milligrams of prednisone. And in a teenager, I give 50 of prednisone. And so I usually stop at 8. The ER stops at 10 for Dexa. And so I think that's one important point when we count is to have a maximum dosage.
Is that okay? I have the habit since residency to do pediatrician only. I won't do Dexa unless
It has much...
1 milligram per kilo, and I think it really gives
along this day. And so we started with this event, and now we're always using DEXA. But you're perfectly correct that, especially in an office, we can give pediatrics. It's much safer. It's not as potent as dexamethasone, and we're not in a setting in an ER where things have to go fast and we don't have any staff. And if a kid vomits, it's too much work for the ER. And so we just started with this event, and then it became we're always giving dexamethasone and asthma for children.
What's the reason that there's more vomiting with pediatrics? The
Volume.
are,
It's 1 milliliter per kilo.
the volumes are not high with the DEXA?
It's very concentrated, and so, and so they put actually 10 milligrams in 1 cc. And so they have a concentrated solution in the ER. It's 10 milligrams for 1 cc. For pediatrics, it's 1 cc per kilo. So if you have a 20 kilo, it's not good. 20 milliliters of pediatrics is something. And the kids are sick, so they just throw up. So I started with this.
When I give pediatrics in my office, I always address throwing up because I tell them to give Ventolin first, wait half an hour, and then the pediatrics.
Or you can use tablets of prednisone and just crush them.
You told
Yeah.
me that. Crush that.
And put them
Yeah,
in.
I like the,
And what do you like to put them in that works well? Because Nutella is.
whatever the parents choose. They put it in something. I would say maple syrup, but it's okay.
I had a couple of quick
Yeah.
comments. Number one, going back to croup and one of your first slides, I'm disturbed that the criteria of 3 courses of steroid within 12 months commits you potentially to going on to onto chronic daily
Yeah.
treatment, because you actually used the word laryngite there. It was on your slide. So somebody might have been treated for croup.
Laryngite, yeah, Rose had a laryngite.
Right.
Yeah, this
And-
is Rose.
And so mistakenly, that child may have had recurring croup, who's now ending up on daily ICS or Monty-Williams or whatever.
No, but the 3 episodes is when they have 3 episodes of using PRN inhalers, then they have to be on a daily dose. If they have 1 exacerbation, 1 using systemic steroids, they're automatically on a moderate daily dose.
Well, even that one, the
Yeah.
problem is that if you're treating a laryngite,
It
or
doesn't
laryngotrachea,
count.
I understand, but it was confusing and
Yeah.
completely confusing for parents. Even the parents themselves don't necessarily know. They got the magic syrup, the kids stop.
Yeah.
I'm just concerned that kids will end up on chronic daily therapy
Yeah.
because they were treated.
Yeah, and we have to separate this completely, because Rose, what happened is she had an asthma exacerbation, then she had a laryngitis, and then another asthma exacerbation. So once DEXA for asthma, you have to put them on a moderate dose of inhaled steroids. But you are correct that croup has nothing to do with this. When we talk about DEXA, we just have to count how much we're giving throughout the whole lifetime, because there's a cumulative dosage. And when we switch it over to prednisone, we can't get it to 500. But if we start counting, it's amazing how much equivalent of prednisone we're giving to children with respiratory problems.
But my second comment comes from 30 years of experience. When I started in the ER a long, long time ago, we used to have rooms filled with asthmatics coming in for mass treatment, and even here in the office, for any of you who started with me way back when, we used to have sick asthmatics coming in here. We're giving Ventolin, getting prednisone. That stopped happening as soon as the world caught on to ICS and started using it early. And
Yeah.
we don't see those crises, we just don't. And now we're taking it back again, and we're saying
Yeah.
we're going to unteach something that's been working. We haven't had endocrinologic emergencies in any great number because of steroids, because of cortisol suppression or immunosuppression. We haven't seen the disasters from using ICS,
Yeah.
but we used to have lots of rest disasters. I think we're going to go, it'll take a generation to change, as you know. I
But
think
maybe
it's a
we should
bad
write back. Well, maybe as a
it's bad
clinic we
change.
should.
It flies in the face of really long clinical experience.
Yeah. Maybe we should write back, but it's, Zofia was there. When it first came out, I wrote about the PFTs. I said, well, the PFTs is really something wrong, and they switched that over. They also had a drawing that they changed. There was somebody taking an inhaler without an aereo chamber. I said, come on, we keep on saying to use your aereo chamber. You put a beautiful drawing, there's no aereo chamber. They changed it, and actually the drawing is not pretty at all. There's no art in it anymore, but I said, whatever, it's just a drawing, we'll forget it. But when it came to this, because it came from Dr. Ducharme and Zofia, I said, okay, so I'm just going to give a talk sticking to what they said to do, because it's going to be throughout Quebec, it's INESSS, and everybody's going to refer to this. Maybe we want to write back to them. But I know that they wrote this, and they didn't ask me to be there, because they know I would say, don't do this, put them on Martin Smart at a lower age, at an earlier stage. And we have been doing Martin Smart, well, not Smart, before the age of 5. And so this is making things more difficult for me, because the minute this came out, when I prescribed Zenel, it's always blocked.
Just write off-label. I mean, I read
Yeah.
tons of block prescriptions, you just write the word off-label.
I do.
And it passes.
I do, but they're more difficult. They say that they have a right not to serve the medication, that they're following what INESSS published at the end of September, and that it has to be ages 6 and more, step 3. So age 6 and more, right, step 3.
We still override it, even we do it with antibiotics all the time.
Yeah.
We don't have any time. It's too high. It's like, so we do it all the time. I think it's just.
Well, maybe we
How
should
it
write
works.
back that we don't agree, but they really outlined this. And I think it has to be mentioned, because if we don't talk about it, well, we're not going to respond to them, but maybe I'll just write back to them and say, well, no. But it's clearly written and it's outlined, and the exception in young children. So I say, well, we'll have to say it because they wrote it. And I know they wrote it for us not to do Martin Smart early on. They don't want us to start doing Martin Smart at step 1 and 2 at ages 6 and above.
I have a question about the DEXA and croup versus asthma. Has anybody ever studied to see that the only people who get treated for laryngitis with croup with DEXA are end up coming out as asthmatics, or is it really that
No.
there's a big distinction?
No, there are some children who have recurrent laryngitis all the time, that some of them have asthma, but you just have to evaluate them. Some
Some of
don't,
them,
some
not
do,
all of them.
not all of them. There's some kids who just have recurrent croup up to the ages of 6 and 7, and whatever you do, they're just going to be this way.
But have all those kids been tested with a PFT to see that they really don't have asthma?
No, not all of them, especially the very young children, and this is the age group that's very difficult. But there are some children with recurrent laryngitis that we treat the postnasal drip, asthma. I always hesitate to treat the reflux, but it's in the 3 things that you should think about. Some do well. If they do well, well, good enough. And then you have to reevaluate them. We always reevaluate in asthma. This is what we do. But there's some kids that just have laryngitis. You don't find anything, and no matter what you do, they're just going to keep on doing it until they're 6 and 7, and then it's just going to stop.
But has a study ever been done to see, like retroactively, those kids that we stopped treating them with, for laryngitis eventually end up on ICS?
No, no, and especially we're talking about very young children, and this is the group that's most difficult in having PFTs.
No,
Yeah.
so eventually, like 6, 7 years old, they
The-
actually
this-
do end up on
no.
ICS.
No, the study hasn't been done. No.
I remember some old literature looking at relationships between croup and reactive airways. They're really two different.
Different things.
Low disease.
But I didn't see anybody like 5 years later doing PFTs in people who used to have recurrent laryngitis to see if they have asthma or not. I haven't seen this.
I would say my own son and my husband would be a very mix-up from that then, because my son had spasmodic croup all the time. Viruses were with the croup, and when he was older, his PFTs were negative, but his respiratory capacity was never good. If the whole family went up the mountain, he and his father were the last ones, and his father was followed by a respirologist. He had PFTs that were positive, PFTs that were negative, on steroids a lot. It just made me think that all these evaluations weren't accurate. Because to me, they looked like they had asthma, both of them, but they had negative tests quite often.
Because if you have a negative methacholine challenge, then you go to exercise testing.
Well, when they skied down the mountain, they wheezed.
Yeah, but I'm talking about in lab, because like we do, yeah,
I was
in
treating
lab.
them both.
Because in lab, you know, like we have athletes, and sometimes we do, we have a negative methacholine challenge, and we really think the person has asthma, then you ask for exercise testing. And then you can find it at exercise testing, and then it's a positive diagnosis of asthma. So if you have a negative methacholine challenge, and you really think that that patient has asthma, you ask for exercise testing.
But you just did an in vivo test, you know, you did, and it clearly
Well,
is, and if you
and
treated
then-
them and then they responded, I mean, by exercising these tests.
And the ex changed his diet and got off all his inhaled cortisones and his asthma was gone. Just from starting smoothies and oatmeal and a healthier diet, and his asthma was gone.
Thank you so much.
I haven't seen that all.
Dr. J.
No, it's difficult, but Ben, we should write to INESSS.